So while we're on the subject of revising, I'm just going to go over the lymphatic system as well briefly. Hello and welcome to Tala Talks NICU. I am Dr. Tala, and on this channel we break down medical concepts and make them super easy for you to understand and then hopefully retain and to apply clinically and to ace your exams, all of it. Many of you have asked us to cover hydrops, so today we are going to be talking about hydrops. As usual, when we start kind of breaking down the videos, we realize that they're too long and you all stop watching before the clinically relevant parts. So we've decided to break this down into two different videos. In this first video, we will cover what is hydrops, number one. Number two, what is the pathophysiology of hydrops, or kind of what causes hydrops. And number three, what are the disease processes associated with hydrops. And in the second video, we will talk about 4, how do you work up hydrops once you've kind of made the diagnosis. 5, how do you treat hydrops? And 6, what are the outcomes of babies that were born with hydrops? Before we continue, I'm going to ask you to like this video and to subscribe to this channel if you're interested in all things neonatal, and to leave us comments with what you would like to watch next. We really do listen to your comments and we try to get the next videos out that people have asked for the most. Let's start at the beginning. Number one, what is hydrops? Hydrops is a really complex condition that happens in babies, and it's mostly diagnosed prenatally. And it is a result of multiple different disease processes that somehow end up with excess fluid accumulation in the fetus. And by definition, the fetus has to have at least 2 abnormal areas of fluid collection to get the diagnosis of hydrops. And this is very logical because, for example, if you just had fluid around the heart and no extra fluid anywhere else, then the first thing that you would worry about is maybe there's just something going on with the heart. So to truly be called hydrops, you have to have excess fluid in 2 out of really the 4 of the potential fluid spaces for fluid accumulation. So the 4 potential spaces for fluid accumulation are: 1, the area around the heart, so the pericardial sac, which was obviously called a pericardial effusion. Number 2, the space outside the lungs, or a pleural effusion, which is within the pleura. Number 3, the area around the intestines, or in the peritoneal cavity, or this is also called ascites. Or 4, you have excess fluid in the skin. And excess fluid accumulation in the skin is diagnosed prenatally when the thickness of the skin is more than 5 millimeters. So if you have any 2 of those 4, then the baby is considered hydropic. Many times babies have 3 or even all of those extra areas of fluid accumulation. And obviously at that point, the diagnosis of hydrops becomes a lot easier. Also, during pregnancy, very often these babies will have polyhydramnios, so they just have loads of amniotic fluid, and they can also have placental thickening. However, those 2 aren't really included in the diagnosis of hydrops. So these babies, as I'm sure you've all seen, are born really fluid overloaded. They're normally really puffy, and very often they're extremely sick. Generally, we divide hydrops into immune and into non-immune hydrops, and I'll talk about the difference between those in a minute. But for now, realize that the vast majority of hydrops is non-immune. So about 90 to even 95% of hydrops is non-immune. And the incidence of hydrops is about 1 in 2 to 5,000 pregnancies. So it really isn't that super rare. Right, number 2. Now let's go over the pathophysiology, or the underlying cause of hydrops. And basically, if you understand this, the disease process that cause hydrops will become really logical. So what we need to understand now is, why would any fetus be in a state where they are accumulating fluid in spaces where they're not supposed to be accumulating fluid? So what I want to go over now is something that everybody watching probably covered in school, whether it's medical school or in nursing school. And that is, why does a body ever become swollen? or edematous. First of all, realize that most of the time when fluid is accumulating in areas it's not supposed to be, that fluid is actually coming out from the blood vessels. So why would fluid actually ever leave the blood vessel? And hopefully a lot of this is actually revision for you. The first reason would be if the vessel walls themselves, so like all the endothelial cells and everything, just became a lot leakier. So it was easier for the fluid within the blood vessels to kind of leave the blood vessels. And so this happens in states of high inflammation. So for example, if an adult is septic, then the capillaries vessels become a lot leakier and that fluid can kind of go into all the surrounding tissue. The second reason, which is a little bit harder to understand, is that there could be low oncotic pressure within the blood vessel. Remember that oncotic pressure is a type of osmotic pressure where proteins within the blood vessel basically pull in the fluid into the capillary vessels, or rather keep that fluid in the capillary vessels. Albumin is really the largest, most important contributor of oncotic pressure within the blood vessels. I kind of want to emphasize this just a little bit more because it really is an important point. So I want you to remember the science experiments that you did in high school, where you had a beaker full of water and in the middle you had a semi-permeable membrane. So in that semi-permeable membrane, basically fluid could go through it, but the solute couldn't. So let's imagine that you just have kind of molecules of sugar throughout the beaker. Now, if you have more sugar molecules on one side of the beaker than compared to the other side, then what will happen is that above everything else, the force will be to try to get the concentration of the solute the same on both sides of the beaker. So what will happen is that the water will travel through the semi-permeable membrane to the side that has higher molecules of solute, trying to make sure that the concentrations on both sides are the same. Exactly the same thing is happening in the human body, except for here, the solute is basically kind of the albumin. So having a lot of albumin within the blood vessel keeps that fluid in there because it wants to stay in there so that the concentration isn't too different from whatever is happening outside the blood vessel. So in this case, the blood vessel wall is kind of like a semi-permeable membrane. So if you have low albumin in your body for whatever reason, then these patients can end up really swollen or edematous. In adults, this happens pretty frequently, for example, in liver failure. The liver produces albumin. So if you're in liver failure, you're no longer producing albumin and you have a low albumin level. It can also happen in nephrotic syndrome, which is where basically you just pee out loads of albumin. Both those types of patients get really, really edematous. And the third reason for fluid seeping outside the blood vessel is when there is literally increased pressure within the vessel or there is way too much fluid within the vessel. The most common reason for this in adults is in heart failure, or more specifically, right-sided heart failure. So when there is right-sided heart failure, the heart doesn't pump as well. So there's like a buildup of pressure before that blood reaches the heart. And so because there's buildup of pressure, then that's why all the kind of fluid can seep out of the vessels and cause patients with heart failure to be much more swollen, especially kind of in their extremities. I just want to add one more thing. One cause of hydrops, which is kind of slightly different from causes of edema in older patients, is having some sort of disruption of the lymphatic system. So while we're on the subject of revising, I'm just going to go over the lymphatic system as well briefly. So the lymphatic system is a collection of vessels that runs parallel to the blood vessel system, but it's completely separate from it. And most of the fluid that collects in the lymph system has actually leaked out from blood vessels. So fluid can leave the capillaries, kind of bathe the cells around it, give the cells whatever they need if necessary, and then it's kind of all collected within the lymphatic system. In addition to absorbing all this kind of excess fluid that's come out from the blood vessels, as you all know, the lymphatic system is a very important component of the immune system. And the reason for this is that there are loads of lymphocytes, or kind of bug fighting cells which are constantly circulating within the lymphatic system. In fact, lymph nodes, kind of like the painful things that you feel wherever, are just collections of lymphatic vessels with a really high concentration of lymphocytes. Lymph travels around the body and then is eventually drained back into the blood through several ducts. The main and the largest duct is the thoracic duct, and it drains on the left side directly into the subclavian vein. So logically, you can also realize that if those lymph vessels become really leaky, or if there's a blockage somewhere, then you could end up with this fluid, this lymphatic fluid that's very high in lymphocytes, actually leaking in to these types of spaces. When it is lymphatic fluid leaking into the space, then it is considered a chylous effusion, because that lymphatic fluid in the wrong space is called chyle, and it's normally extremely rich, as you would expect, in lymphocytes. Most of the time, chylous effusions happen within the chest, because that's kind of where a lot of the lymphatic system returns into the blood vessels. So a lot of the blockages and the leakages can happen there. So a chylothorax, if it's severe enough, can also result in a hydrops. So let's summarize and just go over the 4 main reasons that there could be a fluid accumulation in a baby and cause hydrops. So 1, you can have leaky capillaries. 2, decreased oncotic pressure. 3, increased hydrostatic pressure. Or 4, some sort of issue with the lymphatic system, whether it's leaky or it's blocked. Right, part 3. Now that you understand that, let's go over the different diseases that can result in hydrops. And if you really understand that part 2 very well, then all of these will seem very, very logical to you. The first thing that you should understand is pretty much a bad abnormality in any system of the body can result in hydrops. Let's start with 1, cardiac abnormalities. These are normally diagnosed within the 3rd trimester of pregnancy, and they account for about 25% of cases of non-immune hydrops. And a cardiac anomaly can lead to hydrops if there's something wrong with the structure of the heart or with the way that it's actually functioning. And really, almost any anomaly of the heart could end up with hydrops. The most common would be a cardiomyopathy from kind of like a Coxsackie or a inborn error of metabolism causing a cardiomyopathy, Ebstein's disease, hypoplastic left heart syndrome, even an AV canal or a tumor in the heart could result with hydrops. So here, remembering what we discussed in 2, the way that you would end up with hydrops is most likely from actual failure of the heart and then increased hydrostatic pressure causing fluid retention everywhere. The second type of cardiac issue that can result in a hydrops is when you actually have something wrong with a functioning, or kind of like you have arrhythmias in the heart. So either the heart could be beating way too quickly, so if you have like an SVT in the setting of, for example, a WPW syndrome, or the heart could be beating really, really slowly, so way too slowly. And this could happen, for example, if the mother has lupus and the baby ends up with a heart block. So what causes the hydrops with arrhythmias? So if the baby's heart is beating really, really quickly, then often the heart itself will just get exhausted and fail. And so it will just kind of give up, not start beating as strongly, and you'll end up increase in pressure before the heart. And if the heart is beating so slowly, then you end up with kind of like a low cardiac output heart failure. Again, probably just kind of increased buildup of venous pressure. The second massive cause of hydrops is anemia. And obviously, as you know, there are many, many different contributors of anemia in a fetus. Generally, if the baby's hemoglobin is less than about 5, so really low, which is basically a hematocrit of less than about 15 or 20, then the baby is at really high risk of developing hydrops. So how does anemia actually cause hydrops? It's thought to be, again, from a heart failure. So because the blood carries the oxygen around the body, If you're anemic, if the fetus is anemic, then its body is just not getting enough oxygen. So the heart beats faster and faster and faster, trying to make up for this relative lack of oxygen. And then eventually, just as before, you can end up with heart failure and again, increased venous congestion and then edema. As you all know, lots of different processes can cause anemia in a fetus, but the one that we've probably talked about the most is the hemolytic anemia that causes an immune hydrops. Immune hydrops used to be really common until somebody very smart in the 1960s figured out a way to prevent it. And now immune hydrops, like we said earlier, only represents about 4 to 10% of the cases of the babies born with hydrops. Let's talk about immune hydrops just for a couple of minutes. So I think most of you probably kind of understand this. The majority of immune hydrops is when the mother is Rh negative and the infant is Rh positive. And during all pregnancies, there's a bit of cross-contamination between the baby's blood into the mother's circulation. So the mother sees this foreign blood in her own circulation, and because it's foreign, the mother will start forming antibodies against the antigens on the fetal red blood cells that were initially just in the mother's blood. However, if she makes enough antibodies, then those antibodies can cross through the placenta into the fetus's blood and start attacking the antigens on the fetal blood cells that are circulating around the fetus. When the antibody combines with the antigen on the red blood cell in the baby's fetus, then it will cause it to hemolyze. So it will cause it to burst open. So this ends up with two things. It ends up with one, normally an increase in bilirubin. In utero, we don't care about this or we don't care about it as much because the placenta will filter that out really well. But what we really care about in utero is obviously if all these red blood cells are being burst, then this baby is going to be really anemic. Rh disease is the most common type of immune hydrops, but really any time a mother produces antibodies against a baby's fetal red blood cells, you could end up with hemolytic anemia that could end up with hydrops. So for example, the mother could be O and the baby could be A or could be B, and that could end up with hydrops. Or mother could even have made antibodies against even less common antigens like the Kell or the Lewis or the Duffy antigens that are found on a lot of red blood cells. The reason why we see immune hydrops so little now is because of the usage of RhoGAM. RhoGAM is given to all pregnant women who are Rh negative, and it is a brilliant drug. Really, it's actually an antibody itself. So what happens is the mother who is Rh negative has already started producing antibodies to the fetus's blood. So you give this RhoGAM, and what it does is the RhoGAM attaches directly to the antibodies that the mother has made. So those antibodies are no longer free to cross into the placenta and cause hemolysis for the babies. Like we said, this has resulted in a huge decrease in the cases of immune hydrops. However, logically, there are also lots of other non-immune reasons why a baby may end up with anemia. The first one could be a fetal-maternal transfusion. So basically, for whatever reason, the baby is bleeding directly into the mother. Or in babies that share a placenta, in twins that share a placenta, there could be a twin-twin transfusion where one baby is basically bleeding into the other baby. One baby ends up really anemic and the other baby ends up fluid overloaded. And actually, in this case, both babies can end up with hydrops, either from anemia or from fluid overload and venous congestion. Some torch infections can also end up with an anemia, and some of the time that's the cause of the hydrops from a torch infection. The most common one to cause an anemia is parvovirus. Parvovirus is also called parvovirus B19, slap cheek disease, fifth disease, but basically it has a high predilection for causing anemia, and that can be a really, really profound anemia. So even though parvo can just be kind of like a cold or a little rash with a bit of fever in kids or adults, if a pregnant woman gets parvo, it can actually be really dangerous. The most common cause of hydrops in Southeast Asia is alpha thalassemia, and that is an inherited disease where the red blood cells basically aren't produced as well and have an increased tendency to break down. So therefore resulting in a anemic hydrops. The third big category of diseases that can end up with hydrops are caused by infections. So the most common infections that can result in hydrops are CMV, toxoplasmosis, parvovirus, like we said, and syphilis. The cause of the hydrops from these diseases is thought to be multifactorial. Like we said already, parvovirus can cause anemia, so that could end up with hydrops from that. Syphilis can also cause an anemia, but it's also thought that just having an infection in the body increases the overall inflammation and increases the leakiness of the capillaries. And the fourth kind of really large group is genetic issues. And genetic issues are responsible for about 12.5% of all cases of non-immune hydrops. Obviously, this encompasses loads of different diseases. I mean, you could argue that alpha thalassemia is a genetic issue, but just for the purposes of this discussion, I'll go over kind of some of the broad categories that it's put in. So kind of the first one is just chromosomal issues. So for example, Turner syndrome, which is XO, trisomy 21, trisomy 13, trisomy 18, are all associated with an increased risk of hydrops. The cause of hydrops in this group of infants with chromosomal issues is thought to be kind of twofold. Either it's related to heart failure, so infants, if they do have a congenital heart disease, or it's related to an abnormal lymphatic system. Either way, if you do have a chromosomal abnormality as well as hydrops, it's a really, really bad prognosis. In addition to chromosomal abnormalities, there can also be very specific genetic abnormalities that can result in a hydrops. For example, a bad skeletal dysplasia, where, for example, the chest is just much, much smaller than it should be. In these cases, it's thought that the chest is literally compressing on the heart and causing some sort of tamponade as well as decreased venous return, increased venous congestion, and that's the way these babies are ending up with hydrops. Again, an extremely bad prognosis. Some of the inborn errors of metabolism, again, genetic diseases, for example, a lysosomal storage disease, can also result in hydrops. And here it's thought that the pathophysiology is that the liver is affected, they end up in liver failure, and they're not producing any albumin. So it's just decreased oncotic pressure that results in the hydrops. And the fifth group are renal anomalies. This is actually a really rare group, a cause of hydrops, but there is one that is frequently tested on boards, and that is a type of congenital nephrotic syndrome. So like we already said, nephrotic syndrome is when the kidneys aren't working properly and they just dump out all the albumin. This type of congenital nephrotic syndrome is called Finnish type nephrosis. Remember that if you're about to do a test. And obviously here, the very low albumin that's in the blood will end up with decreased oncotic pressure and then hydrops. And then number 6, gastrointestinal issues can cause hydrops. So for example, you could have a perforated bowel or a meconium peritonitis. And here you can obviously, in these situations, you're probably going to end up with ascites just because there's loads of inflammation there. And then very often they can end up with skin thickening as well. Most likely the cause of hydrops there is just the overall inflammation and the leakiness of the capillaries. Generally, these causes of hydrops have a better prognosis. There are many, many other diagnoses as well that can end up with hydrops. They're all just pretty rare, and so they're not necessarily categorized within a system. But many tumors can end up with hydrops as well, so a sacrococcygeal teratoma or a neuroblastoma. Also, different abnormalities in the lungs like a CDH or a CPAM can end up with hydrops, even like a thyrotoxicosis. So if a baby has a really, really high thyroid level, then that can end up with hydrops as well. And then in about 30% of the cases, we just never find the diagnosis of the hydrops. Sometimes the babies will just kind of get better after birth, and sometimes, unfortunately, they just don't make it. And despite all the testing that we do, we never really find an etiology. Well, that sums up all the causes of hydrops and all the kind of different diseases that can result in hydrops. What I want you to learn is that it is an absolutely massive, massive list. Please stay tuned for the next video where we'll discuss the workup and the treatment and the outcomes of infants with hydrops. In the meantime, please remember to subscribe if you're interested and to leave us a comment on what you would like to hear about next. Thank you so much for being here.